Dr. Vidal. I'm a second-year internal medicine resident at RMC, and today I'll be presenting to you the first case of high-risk acute myelogenous leukemia in a Jehovah's Witness patient treated in community hospital setting. So, introduction. The modern Jehovah's Witness organization was established in the late 19th century, and the adherent of this faith typically refuse blood transfusions and blood-related products. The refusal is particularly significant in patients that have AML because of high risk of severe cytopenias, not only from the traditional chemotherapy but also from the disease itself. And in young fit patients that have acute myelogenous leukemia, the treatment is usually aggressive 7+3 regimen with a curative intent. Jehovah's Witness patients that do refuse blood products, they're usually treated with less aggressive regimen consisting of hypomethylating agents and BCL2 inhibitors. However, it's only for palliative intent. So we had a 29-year-old Jehovah's Witness patient with past medical history significant for iron deficiency anemia and menorrhagia, presented to our hospital for easy bruising. Her workup for non-neoplastic etiologies was negative, so a bone marrow biopsy was obtained, which was positive for AML with 70% blast. Her cytogenetics came back positive for chromosome 8q deletion and NF1 loss on 17q, essentially making her high-risk AML. We had an extensive discussion with her regarding the blood products, and she continued to refuse. We also offered to transfer her to an academic center experienced in this type of treatment. However, she preferred to stay in Orlando and get treated at RMC. She was started right away on supportive medications such as EPO, IV iron, folate, and B12. Patient started to have her period during that visit, so she was discharged on iron and was asked to return to the hospital 7 days later. Once she readmitted to the hospital, we started her on palliative chemotherapy with Vidasa Veneto for 7 days. During her hospitalizations on day 12, she became febrile and had a neutropenic fever. She was started on broad-spectrum antibiotic, and the fever resolved. The repeat bone marrow biopsy on day 28 showed residual leukemia, 10 to 15% blast. After her discharge from the hospital, she has so far had 2 cycles of Vidasa monotherapy. Veneto wasn't started because of severe anemia and fatigue. As you can see, these are the CBC trends during her treatment in the hospital, where hemoglobin dropped all the way to 3.7 at one point. So, discussion: acute myeloid leukemia is the most common acute leukemia and the second most common leukemia overall. The Jehovah's Witness organization basically makes up about 1% of the US population. There are only limited cases of AML treatment in Jehovah's Witness patients, largely because of such a high mortality associated with these treatments. Most published cases are, however, in an academic center where the chemotherapy regimens are adjusted to accommodate. One study that was found in literature showed low-dose chemotherapy in Jehovah's Witness patients results in lower remission rate, higher relapses, and increased mortality due to the severe anemia. Another report in literature described a Jehovah's Witness patient that was treated with a different regimen, cytarabine, valproic acid, and vinblastine, that survived 8 months without any transfusions. However, the cytogenetic was never done on that patient, so we don't know if that patient was low risk or high risk. In 2020, a case published by University of Colorado treated high-risk Jehovah's Witness AML patients with the same regimen that we did and had a durable remission. However, that was an academic center. There are multiple prognostic systems that are used for AML, ELN being one of them that helps stratify these patients. However, they don't really apply to patients that don't receive blood products. So our case is the first known instance of Jehovah's Witness patients that are high risk treated in a community hospital setting without any blood transfusions and had the severe anemia of hemoglobin 6.7 and nadir of 3.7.